Bowel ischemia, also known as intestinal ischemia, occurs when there is an inadequate blood supply to the gastrointestinal GI tract. This condition can affect the small intestine, large intestine, or both. Reduced blood flow can lead to tissue injury and necrosis, potentially resulting in life-threatening complications if not treated promptly. Types of bowel ischemia. 1. Acute mesenteric ischemia, AMI, a sudden decrease in blood flow to the intestines. Common causes: arterial embolism, blood clot from the heart, e.g. atrial fibrillation, myocardial infarction; arterial thrombosis, atherosclerosis in mesenteric arteries; venous thrombosis, obstruction of venous outflow, e.g. hypercoagulable states, malignancy, infections; non-occlusive mesenteric ischemia, NOMI, hypoperfusion without vascular obstruction, often seen in critically ill patients. 2. Chronic mesenteric ischemia, CMI, gradual reduction in blood flow due to long-standing atherosclerosis. Typically affects elderly patients and presents with intestinal angina, postprandial pain. 3. Ischemic colitis, the most common type of bowel ischemia, usually transient and affects the colon, large intestine, particularly watershed areas like the splenic flexure, caused by hypotension, hypovolemia, or low blood flow states. Causes and risk factors. Vascular diseases, atherosclerosis, peripheral arterial disease; cardiac conditions, atrial fibrillation, heart failure, valvular disease; thrombophilia, hypercoagulable states, e.g. malignancy, inherited clotting disorders; low blood pressure or shock, hypotension, sepsis, dehydration; trauma or surgery, damage to mesenteric vessels; medications, vasoconstrictors such as digitalis or cocaine; age, older adults are more susceptible; symptoms. The clinical presentation depends on the type and severity of ischemia. Acute mesenteric ischemia, sudden, severe abdominal pain, disproportionate to physical exam findings; nausea, vomiting, or diarrhea; bloody stools in advanced cases; signs of systemic shock, e.g. tachycardia, hypotension. Chronic mesenteric ischemia, recurrent postprandial abdominal pain within 30 minutes to 2 hours after eating; unintentional weight loss due to food aversion, diarrhea, or constipation. Ischemic colitis, lower abdominal cramping or pain; bloody diarrhea or bright red rectal bleeding. Symptoms are often mild and self-limiting. Complications: bowel infarction, necrosis, leads to perforation, peritonitis, and sepsis; strictures or chronic scarring in ischemic colitis; persistent malabsorption in chronic cases; death if untreated. Diagnosis. A prompt and accurate diagnosis is crucial. 1. Clinical evaluation, detailed history and physical exam, assessment of risk factors and systemic signs. 2. Laboratory tests. Elevated lactate levels suggest tissue hypoxia; leukocytosis, metabolic acidosis, or elevated D-dimer. 3. Imaging. CT angiography, CTA, gold standard for acute mesenteric ischemia, identifies vascular blockages or bowel necrosis. Doppler ultrasound, useful for evaluating mesenteric vessels in chronic cases. Colonoscopy or sigmoidoscopy for ischemic colitis, revealing mucosal changes or ulcers. 4. Exploratory laparotomy, required in cases of peritonitis or suspected bowel necrosis. Treatment: acute mesenteric ischemia, resuscitation, IV fluids, correction of electrolytes, and management of shock. Anticoagulation, heparin for arterial or venous thrombosis. Surgical intervention, revascularization, embolectomy or bypass, resection of necrotic bowel if irreversible damage occurs. Endovascular approaches, angioplasty or stenting. Chronic mesenteric ischemia, lifestyle modifications. Control atherosclerotic risk factors, e.g. smoking cessation, lipid-lowering drugs. Revascularization, endovascular or surgical options. Ischemic colitis, supportive care, IV fluids, bowel rest, and antibiotics for moderate cases. Surgery for severe cases with gangrene or perforation. Prognosis: acute mesenteric ischemia, mortality remains high, 50 to 70% if not treated early. Chronic ischemia, favorable prognosis with timely intervention. Ischemic colitis, generally good, as most cases resolve with conservative management. Prevention: manage cardiovascular risk factors, e.g. hypertension, diabetes. Regular use of anticoagulants in at-risk individuals, e.g. atrial fibrillation. Timely treatment of shock or hypotensive states. Prompt recognition and intervention are critical in improving outcomes for patients with bowel ischemia.